Hello folks, in this video we're going to talk about a very challenging situation, which it is a patient with vitreous hemorrhage. In the past, when vitrectomy was not so safe, the usual routine management of vitreous hemorrhage was just wait and let it go as long as the patient does not have a retinal detachment. Nowadays things changed. There is a trend among retina specialists and ophthalmologists to manage and intervene patients with vitreous hemorrhage early, within the first few days, for several reasons. First, B scan or ultrasonography is sensitive to tears or retinal detachment in only half of the patients. In addition, up to 1/3 or even more percent of the patients with vitreous hemorrhage and non-diabetic will have a retinal tear with a normal B scan. If the vitreous hemorrhage is non-resorbing, persistent, the rate of retinal detachment of retinal tears is even higher, maybe up to 2/3 of the patients with a retinal detachment or retinal tear. In addition, if the patient has a vitreous hemorrhage and develop a retinal detachment, the risk of proliferative vitreoretinopathy or failure of the retinal detachment repair is higher. The chances of the patient are lower if you wait too long. So bottom line is, when you have a patient with vitreous hemorrhage, follow that patient very closely. Of course, perform always a B scan, try to scan and search for tears and detachment or masses. And if the patient is non-diabetic, which is a different situation than what we're talking here, follow the patient every 2 or 3 or 4 days and consider early vitrectomy within the first few days after the initiation of a vitreous hemorrhage. Nowadays, with the small gauge, high speed, high cut rate of the vitrectomy system, the rate of complications of vitreous hemorrhage surgery is very low. I hope you like this short discussion about this important topic of the early intervention for non-diabetic vitreous hemorrhage. See you in the next video.